Anand Raju from Coimbatore, presenting Unraveling Tongue and Epiglottis Dynamics in OSA.
Good afternoon, Dr. Anand Raju from Coimbatore. So, this is a real boring topic actually. So, this understanding the dynamics is really difficult. So for a lot of presentation regarding the surgical management, dyes and everything, but so I'm not going to bore you. So, to wake you all understanding sleep surgery is really important to master the sleep surgery. Dynamic is successful, but understanding dynamics is important actually. So you know that actually almost 1 billion of adult people and all throughout the world actually suffered with the sleep apnea. 14% is a male prevalence and 5% is a female prevalence. You know that actually the airway dynamics is totally different. This is a normal airway. So the dynamics is actually the airway is very pattern. Actually this is abnormal airway. The Bernoulli's phenomena plays a very important role in sleep apnea. So the upper airway is a complex muscular structure. So it starts from the nose to the glottis, actually without no bony support. It's only a muscular support with almost 24 muscles plays very important role in maintaining the airway. So along with the cartilage and little bony landmark. The nasopharynx and velopharynx and oropharynx and hypopharynx. You know that hypopharynx is a critical area, is always underappreciated in this sleep apnea surgery. So already we discussed about these areas of interest in sleep surgery. So muscle of tongue is actually divided into extrinsic muscle and intrinsic muscle. The extrinsic muscles of the tongue plays an important role as a protruders as well as retractors. The protruders are genioglossus muscle, verticalis and transverse. So always airway, the extrinsic muscle, so there are 8 muscles. So 4 intrinsic and 4 extrinsic muscle, all sub-innervated by the hypoglossal nerve. The protruded muscle move the tongue blade and base of the tongue forward, actively dilating the pharyngeal airway. The retractor muscles pull the tongue backwards towards the posterior pharyngeal wall. The genioglossus muscle is the most critical muscle for maintaining the airway patency during sleep, providing the primary anterior force that prevents tongue base collapse. So that's why this hypoglossal stimulation always depends upon the genioglossus muscle activity. So both combination of this intrinsic as well as extrinsic muscles plays an important role maintaining the airway stability during sleep. So this is the tongue musculature. So this is our extrinsic muscle, these are all intrinsic muscles. So genioglossus is the essential guardian of the upper airway patency. It has 2 bundles, anterior bundle as well as a posterior bundle. Middle bundle is also there, but middle bundle is insignificant. The anterior bundle is almost, actually it's a type 2 fibers. Is the main action is actually, is always to pull the tongue protrusion, pull the tongue anteriorly, always produce tongue protrusion, maintain the widen the posterior airway. So actually it's a primary airway dilator. The posterior bundle is actually as a type 1 fibers is to maintain the tone of the muscle. Actually it's mainly stiffening and maintaining the shape of the tongue. So whenever there is a wakefulness, there is a high activity of a tone is there. In NRM sleep, reduced but is sufficient to maintain the tone of the tongue musculature. But in REM sleep, almost complete atonia. Because of the atonia, the tongue muscle is more prone to collapse. So that's why the hypoglossal nerve stimulation plays an important role in REM sleep. Whenever there is anterior posterior collapse, it plays an important role to pull the tongue forward, so to stimulate the hypoglossal nerve. The intrinsic muscle is actually maintain the shape and stiffness of the tongue by the hydrostatic principle. What is hydrostatic principle? Hydrostatic principle is a muscular hydrostate. It's a structure composed entirely of muscle with no rigid skeletal support like octopus as well as like the elephant trunk. It maintains near constant volume due to incompressibility of the muscle tissue. Whenever you compress a muscle of the tongue, it won't compress actually. So it always maintain the volume of the tongue muscle. The hydrostatic property means contraction of one muscle group forces elongation or expansion in another direction. The four intrinsic muscle use this principle to achieve precise three-dimensional shape changes without any bony attachment. The transverse muscle as well as superior longitudinal muscle shorten the tongue. It actually runs along the dorsal surface, shorten and curls the tongue tip upward. And the inferior longitudinal muscles retracts the tongue. Transverse muscle narrows the tongue. Vertical muscle flattens the tongue. Along with its transverse and vertical muscle is maintaining the tongue stiffening is very important. These two muscles are very important to maintain the airway stability as well maintain the tongue tone actually during the sleep. So sleep related changes, coming to the pathophysiology, sleep related changes in control fundamentally alter the airway stability. So you know that actually wakefulness, the full tone is there. In NRM sleep stage 1 and 2, this reduced somehow actually is sufficient to maintain the stability. In stage 3, almost is very low. Suppose if the tone is very less, the chance of collapse is more. Normally in DICE actually we can stimulate NRM, but is not able to stimulate REM sleep. In REM sleep there is a primary tone is completely lost. So this REM sleep is actually common, more apneic episode as well as more, so collapse may occur in REM sleep. So another thing is the mechanoreceptor reflex arc. So actually there is a lot of mechanoreceptors situated in the pharyngeal airway. This mechanoreceptor stimulation is less in REM sleep. There is no stimulation from this mechanoreceptor. So this receptor as well as the tone from the central nervous system as well as the mechanoreceptor reflex arcs, both are very important to maintain the tone of the tongue muscle. Both are actually very less in the REM sleep. So REM sleep is the more notorious phase of sleep cause more or less more collapse and more apneic episodes. So coming into the pathophysiology again, so the three factors are very important. The anatomical predisposition and sleep-related muscle dysfunction. One is the gravitational displacement. Tongue is actually no upward support, all downward support. Genioglossus muscle, even hyoglossus muscle and styloglossus all actually pull the tongue back. So no upward this thing. That's why the supine position displaces the tongue posteriorly as worsened by neck flexion. That's a positional OSA is a direct manifestation of this mechanism. Whenever you change the position, lateral position or maybe prone position, the chance of actually the OSA may be less. REM sleep genioglossus atonia, already we discussed. Anatomical predisposition, actually a lot of anatomical deformity like actually sometimes macroglycia, low hyoid position, narrow mandible and ectonathia, obesity, so short neck, all actually this tongue volume is high but actually the box is less. That's why the tongue may collapse backwards. The anatomical predisposition also very important factor, so they alter the aerodynamics of tongue. Then coming into the epiglottis, so you know that anatomy is actually leaf-shaped elastic cartilage located at the base of the tongue, forming the anterior wall of the laryngeal inlet. Unlike the hyaline cartilage of larynx, it's composed of only yellow elastic cartilage. So that's why it's easily deformed during actually very high negative inspirative pressure. It's attached with actually thyroid cartilage with thyroepiglottic ligament as well as it's attached with the hyoepiglottic ligament. This is important ligament actually. So lateral margins are connected to the arytenoid cartilage by AE fold and it's to the tongue with the median and later glossoepiglottic fold. So there are a lot of shapes. So leaf shape and omega is a very common shape one. So that it's no muscle support at all. So actually no muscle support, long free superior margin and tongue based dependency. These all three factors are very important actually. That's why the epiglottis collapse is very common in case of actually tongue based collapse. Suppose in case of very high intraluminal pressure, automatically with no muscle support is actually go and completely plaster the posterior pharyngeal wall. So elastic deformity, actually the high elastin content allows the epiglottis to deform under negative pressure. So otherwise called the floppy epiglottis. So all these factors are important to assess, so this determine the dynamics of epiglottis. These are the shape of the epiglottis. So type 1 is omega shape and the type 2 is a normal concave and type 3 is a flat epiglottis. So this is a primary collapse. This is one the primary collapse. This is the examples of primary collapse with a hyperlax epiglottis, otherwise called the floppy epiglottis. This is the secondary collapse, book shape epiglottis collapse. The length of epiglottis also in one paper, actually one literature, the length is actually suppose more than 16.6 mm is actually they are more prone to develop actually primary epiglottis collapse. But I think so it's not significant. It's only one literature is there, but I don't know whether it's really relevant or not. This hyoepiglottic ligament, long-standing actually epiglottis collapse, otherwise actually tongue-based collapse. So that degeneration of this hyoepiglottic ligament allows epiglottis to fall easily backward and plaster to the posterior pharyngeal wall. That's why this hyoepiglottic ligament is also important. And during our surgery, epiglottis stiffening surgery, just you fibrosis this hyoepiglottic ligament. So actually it pulled the epiglottis back. Even in the operating intraoperative setting itself, you can visualize the improvement. So coming to the epidemiology actually, during routine dyes, awake endoscopy, normally we can't judge how much the prevalence of epiglottis collapse. Only the dyes really help us to identify the prevalence of epiglottis collapse. In normal population is actually only 12.5 to 32% of prevalence of epiglottis collapse. But in CPAP failure population is almost more than 75%. In post-surgical failure is almost more than 40%. Isolated epiglottis collapse is only 13 to 24%. It all depends upon the diagnostic method. Suppose you do only awake endoscopy, is very less. Suppose you have a suspicious of actually post-operative failure or maybe CPAP failure, suppose you do a DICE, this prevalence is increased. So another classification is a poor distinct morphological type of epiglottis by this Francia and Lugo classification in 2020. So they did actually DICE in 74 patients and they assessed the epiglottis pattern of collapse. There is 4 type of classification. One is type 1 is a trap door, is a 48%. Type 2 is actually a secondary collapse, is a flappy secondary collapse is 24%. So type 2 actually, so 1 second. Type 2 is a secondary and type 3 is a book type collapse is around 14%. And flappy is a circumferential collapse is very rare actually, so around only 13.5%. So it's, but it's normally is a trapdoor phenomena also we used to call it a flappy epiglottis. This type 4 is exclusively flappic, so no cartilage itself actually sometimes it's a collapse like a circumferential collapse is very rare. So it's a diagram for classification. So trapdoor phenomena is isolated anterior posterior epiglottis collapse is a very common, is a 48%, but actually is actually the thing is suppose you suspect as a very thin individual but AHI is more than 60, definitely you have to think about epiglottis collapse. Maybe the BMI is less than 30, age is younger patient, sex is female predominance and always there is poor response to CPAP, always think about epiglottis collapse, maybe it's a trapdoor phenomena. The mechanism is driven by elastic deformability of the epiglottis cartilage combined with the absence of intrinsic muscular support. During inspiration, so development of the high intraluminal negative pressure, the epiglottis itself sucks inside and almost closes the posterior pharyngeal wall. So this is a very common, this primary isolated event. Suppose you suspicious of actually very thin individual with a severe OSA, always think about the epiglottis collapse. So the 3 points are very important actually. The primary site collapse in the secondary epiglottis collapse is primary site collapse, maybe the tongue base or lateral pharyngeal wall or huge tonsil can push the epiglottis back, or maybe the epiglottis actually it's compressed laterally, maybe book type epiglottis collapse. So next one is a negative pressure zone created whenever there is a high intraluminal pressure. So always suck the tongue base posteriorly as well as it causes pressure over the epiglottis and causes epiglottis collapse. The epiglottis drawn posteriorly by itself because of the high intraluminal pressure and complete multi-level obstruction, maybe the soft palate or maybe in the oropharynx level or maybe in the tongue base, all created a high intraluminal negative pressure. It's a progressive intraluminal pressure. Suppose the pressure lot of people actually you observe during the early DICE actually you won't feel any tongue base collapse, you won't feel any epiglottis collapse. When actually slowly the time progress, maybe 10 minutes or maybe 15 minutes later, the high intraluminal pressure created at that time you experience a tongue base collapse, automatically push the epiglottis back, always cause the complete laryngeal inlet collapse. That's why it's understanding the Bernoulli's phenomena as well as Starling resistor law is very important to identify the actually to know the dynamics of tongue base as with epiglottis collapse. Bernoulli's effect explains dynamic pharyngeal narrowing during inspiration. So it's not a big thing actually. Bernoulli is a fundamental of law of fluid actually. So it's actually applies over the OSA. Whenever there is decrease in the pressure of the entry, so increase the pressure is normal. The pressure is a wide airway segment. The pressure is low, so the high intraluminal pressure will be there. Whenever the entry point, the pressure is very high negative pressure at the entry of nose or maybe in the nasopharynx, it creates very low as well as very high negative intraluminal pressure. Very high intraluminal negative pressure automatically suck all the structure like a soft palate or maybe tonsil or maybe the tongue base or epiglottis back and completely cause collapse at the laryngeal inlet. That's why understanding Bernoulli's phenomena is very important to know the dynamics of tongues and epiglottis. And Starling resistor law actually, so this peak rate is the very important thing. The Starling resistor model actually is airway is a collapsible tube. The nose is a rigid tube and trachea is a rigid tube. In between the airway is a collapsible tube. Whenever the pressure more in the nose, automatically cause collapse in the midline. It causes collapse of the our upper airway. That's why this critical closing pressure is the intraluminal pressure at which the airway collapse. When the upstream driven pressure from inspiratory effort falls below the peak rate, his airway always closes. The peak rate is always a high negative pressure. It's a minus 13 centimeter of water. In normal OSA patient, the peak rate is between actually 5 to minus 8 centimeter of water. In mild to moderate OSA, the peak rate almost rises is minus 5 to at least normal atmospheric air pressure. In severe OSA, peak rate is actually more than the atmospheric pressure. That's why it's a period severe collapse is there. This is actually diagrammatic representation of Starling's law. The first one is the green was a normal one. So the PUS is upstream pressure, peak rate is a peak critical pressure, the PDS is a downstream pressure. So actually the upstream pressure is more than peak critical pressure, is always the airway is normal. When actually is a normal critical pressure, almost the upstream pressure is almost equal to peak rate. So actually there is an inspiratory flow limitation. In critical pressure is more than the upstream pressure, almost the complete collapse is the airway. This is the complete apneic episode, complete is describe the OSA. So we need to know about actually what are the structure causing collapse, know about the tongue base collapse, so as well as epiglottis collapse. So already everyone discussed about the drug-induced sleep endoscopy. So drug-induced sleep endoscopy, we can assess velum and the what classification, the common classification what we use normally. So this is a so there's a huge tongue base pushing the epiglottis back. So one of the dies. So as well as the epiglottis itself, it's a little floppy and falling back and closing the posterior pharyngeal wall. So another dies. Is epiglottis itself actually. There is no compression from the lateral. Epiglottis itself causing closing is also booked like say this is a type 3 collapse. So above the epiglottis there is a tonsil lateral collapse. The epiglottis itself causing C-shaped collapse, complete collapse at the level of epiglottis. Only we can assess the collapse of the epiglottis. Without dyes, actually we can't identify the epiglottis collapse. Classification already we discussed. So diagnosis always depends upon the dyes. So whenever the BMI is less and young individual and the CPAP intolerance, always you have a suspicious about epiglottis collapse. So this OSA prevalence normally obese individual is 48%, obese female is 38%. The epiglottis collapse in unselected OSA is around 16. In failed CPAP it's around 40. In post-surgical failure the almost goes up to 70. So epiglottis collapse in highly prevalent patient with failed CPAP or previous surgery is all repeated one. So the surgical methods, so already everyone discussed about the surgery. So there is a coagulation assisted tongue base reduction and epiglotopexy. So the thing is actually you can use a microscope or you can use a 45-degree endoscope with actually small blade, boiled with mouth blade, and pull the tongue anteriorly and push the endotracheal tube little further below and hold the huge tongue, and you can use EVAC 70 or maybe you can use ProSize 1, and you can cut the tongue. Muscle is a tailor-based one. When you see a sign of bleeding, you can stop. So believe me, actually, so you maintain the midline, the bleeding is very less. Once you remove the adequate tongue base, you are able to see the epiglottis. Suppose you feel epiglottis itself collapse, you can cut the epiglottis itself. So a lot of surgical procedure, so epiglotopexy, stiffening of epiglottis, or you can opening the epiglottis like a book. You can cut the midline, V shape or U shape. So this is once you feel this stiffening is just you make a fibrosis just to do the coagulation at the tongue base as well as the epiglottis, so as well as you just fibrose the hyoepiglottic ligament. Otherwise you can cut the epiglottis superior margin. So this is a midline glossary. Suppose you feel the tongue diameter is huge, you can reduce the midline tongue. This is again with the same EVAC 71. Is all tailor made, so depends upon the surgeon. So strict midline is rule. So 3 into 3 or maybe 2 into 2. So 2, 3. So in midline 3 the lateral. Wait one. 2 minutes more. So once you see the sign of bleeding, you can stop. But suppose you strictly maintain the midline, so there will be no bleeding. So the another newer technique is a hypoglossal stimulation. So I'm not going into the detail. So it stimulates inspiration detected by sensor, stimulation delivered to the hypoglossal nerve. Tongue protrude anteriorly, airway opens. This is a mechanism of hypoglossal nerve. So almost 68% of key outcome actually in 12 months actually success rate. So surgical success rate is almost more than 76%. So multiple surgical approach for epiglottis. So I will go in. So this partial epiglotopexy. The same one. Okay. So that one is with the microscope, sometimes very difficult to see with the microscope. So this is a 45 degree. So the same surgical method. So this is all the same. So once you resect the epiglottis, so nothing to worry about aspiration. So even though you remove the epiglottis, the chance of safety mechanism is very good. So the stiffening surgery is nothing but actually, so already we discussed, is just coagulate. Not ablate, coagulate at the base of the epiglottis along with the tongue base. So automatically it will plaster over the tongue base during healing period. So it will improve the epiglottis collapse post-operatively. The upper airway stimulation, emerging neurostimulation technology for direct pharyngeal muscle. So the future direction is neurostimulation is closed loop artificial intelligence driven stimulation, multi-site stimulation, simultaneous hypoglossal and unsar cervical stimulation, and fully leadless system and expanded patient phenotypes, all this future direction. So the key so understanding tongue and epiglottis dynamics enables personalized effective OSA management. These 5 points are very important. Tongue base collapse is the most common collapse in OSA. Epiglottis collapse is prevalent and frequently missed without DICE. The classification, Franco and Lugo classification provides clinically actionable framework. DICE is moderate for all cases before any surgical intervention. Targeted therapy achieve excellent outcomes when matched to collapse pattern. Maybe it's anterior collapse or trapdoor phenomena, or Buxé collapse, or maybe secondary collapse. According to our degree and pattern of collapse, targeted therapy really helps well. This is the OSA management algorithm. So you diagnose OSA with polysomnography, offer CPAP therapy for at least 2 to 3 months. CPAP is really successful, ask them to continue CPAP and follow up. If there is no improvement with the CPAP, perform DICE evaluation. So you see a multi-level obstruction, do a multi-level surgery in single stage. So and follow for PAG at 3 to 6 months, adequate response, So reassess, just to continue the management, suppose no response, reassess and redo a polysomnography and re-dice, and modify your surgery, maybe revision surgery. Thank you so much for patient listening. Thank you.
Thank you, doctor.